I want to start with a story. It was 2014, and I had just finished my residency in internal medicine. I was shadowing my mentor, Dr. Mochtinger, in his clinic. His patient, let's call her Anna, was a 40-year-old woman living with HIV. She was telling us that she believed in the power of her body to heal itself through natural remedies. Anna had been out of care for years after she was laid off and lost her insurance. She would show up at urgent cares or hospitals, but she never took the medications that they prescribed. Her response was always the same: I trust my body. I worried that she would die soon without treatment. I thought, how do I convince her? How do I educate her? How do I get past that implicit suggestion? I trust my body, but I don't trust you. Now let me ask you a question. Have you ever been frustrated that a loved one won't go to the doctor or chooses to listen to medical misinformation online? Have you ever had a negative experience with our healthcare system? It turns out a lot of us would say yes. According to a national survey of thousands of Americans, trust in physicians and hospitals has plummeted by over 30% in just the last few years. This should worry all of us, since medical mistrust is linked to worse health. Studies show that higher mistrust is associated with worse perceived health, fewer visits to primary care, fewer preventative cancer screenings, and higher mortality rates overall. So why all the mistrust, and why is it trending upward? Common explanations include patient experiences of discrimination or a preference for homeopathic cures, paternalism and disrespect from doctors, and disillusionment with our profit-driven healthcare system. Conspiracy theories, the proliferation of medical misinformation online, and political manipulation of medicine are often also cited as key reasons for mistrust. I've been a primary care doctor for over a decade, and I've learned something from talking to patients from all walks of life, something I want to share with you today. That something was the same thing that had been missing in Anna's life before she met Dr. Mochtinger. Anna saw Dr. Mochtinger frequently over the next few months. She still wasn't taking her medications, but she was showing up. During those visits, Dr. Mochtinger would always greet her with warmth and interest. He would ask her, "How are you doing? How is life? What problems do you want to focus on today?" Sometimes it didn't seem like we were doing much in these visits, not compared to what I was used to. There weren't a lot of orders or referrals, but he was very intentional. Those visits, those conversations, those kind words, they were building blocks. One day, we looked at Anna's labs and we shared with her the news that her HIV had progressed to AIDS. She was devastated. She held her head in her hands and sobbed. I remember her saying, "I failed." Dr. Mochtinger walked over to her and he sat down beside her. He laid a hand on her shoulder, and in his words and actions, he wasn't judging, just supporting, witnessing. There was a clock ticking on the wall, but he let the silence linger. She looked him in the eyes. Finally, she said, "I'm ready to take the medication." He nodded. "Okay, I'll be here with you." That memory has stuck with me for years. When Anna first said that she wouldn't take medications, I thought the problem was ignorance. I wanted to use my medical education to teach her, but that would have only created resistance. What ultimately changed her mind, the something that had been missing while she was bouncing between urgent cares and hospitals, was the relationship that she now had with her doctor. That something is also the diagnosis we're missing when we talk about medical mistrust. Medical mistrust is a relationship issue. Medical mistrust is rising because people are losing the long-term doctor-patient relationships that used to be the foundation for trust. Primary care doctors are usually the first people you meet when you enter healthcare. We treat the whole person rather than one organ or one disease. We get to know patients over time. We learn about their lives, their families, and what matters most to them. Relationships in primary care are critical because the experience of being a patient can feel very vulnerable. I mean, what's more vulnerable than ceding control of your own body? When it's cold outside, and I want to put a coat on my 2-year-old, and he doesn't want to put on his coat, God help me, you would think I was cutting off his legs. I used to think he was insane, as all parents of toddlers do. But that frantic reaction of, this is my body, is actually deeply human. The need for autonomy doesn't go away at age 2. We just learn to control it. But now imagine yourself in a doctor's office. You're naked under a gown, you're sitting on butcher paper, waiting for somebody to ask you very personal questions. Now imagine if you have a history of personal or medical trauma or discrimination. That inherent power imbalance between doctor and patient heightens vulnerability, especially if you've been mistreated. Perhaps the most infamous example of medical abuse and mistreatment is the Tuskegee experiment. In 1932, 400 African American men were recruited by the U.S. Public Health Service Tuskegee study to evaluate what they were told was bad blood. What they weren't told was that bad blood meant that they had been diagnosed with syphilis. The study doctors wanted to see what happened over time to the men who were living with syphilis versus those who weren't. For 40 years, as the study went on, those men weren't given information about their diagnosis. And when penicillin became the standard treatment, the cure for syphilis, those men weren't offered it. Some of them unnecessarily died because of the lack of treatment. When the COVID-19 vaccine came out, many of my patients wouldn't get it. I remember one saying, "I don't want to be experimented on." They pointed to the Tuskegee experiment as proof that health and government experts can't be trusted. They worried they would be tested on rather than treated. When people have been mistreated or abused by the medical system, when they've had negative experiences in healthcare, mistrust is a protective reflex. And we bring our past traumas into future relationships. That's true in life and in healthcare. But the connections and the relationships we can make in medicine sometimes can heal those wounds. I learned that firsthand from another patient. For the sake of privacy, I'll call him Edgar. At our first visit, my medical assistant noted that he had a history of high blood pressure, heart failure, and diabetes, but he had been off all of his med for months. I made a checklist of what I needed to do for the visit. In the next 15 minutes, I needed to get new labs, I needed to restart his medications, including his insulin, I needed to talk to him about quitting smoking, and I needed to get him a couple of vaccines that he was due for. I was ready to dive in, and I entered the exam room and introduced myself. "Hello, I'm Dr. Norwood." He looked at me skeptically from across the room. His arms were crossed. After a minute, he said, "Sorry, I just don't trust doctors." I stopped. I folded my checklist and I put it back in my pocket. His mistrust was a vital sign. It was a signal to stop. And it was just as important as his blood pressure. I just hadn't been trained to measure it. Edgar's message in that moment was, "Don't tell me what to do without first earning my trust." Now, throughout medical school and residency, I had learned to become extremely efficient. I learned how to walk into a room and set an agenda, focusing on the most urgent medical issues. I learned to listen to my patient while taking notes, while typing in lab orders and referrals and imaging, while keeping one eye on the clock, while creating a differential diagnosis in my head, sometimes speaking in Spanish while typing in English. In a busy clinic, these are survival skills. But while efficiency hacks and streamlined workflows can expedite medical care to a point, they can't take the place of conversations that build trust. There aren't shortcuts for that. And I knew that if I barreled through, Edgar probably wouldn't come back. So that visit, I asked him to tell me more. And as we talked about his healthcare experiences, the good and the bad, I got to know him, and I learned more about him. It turns out that where he grew up in rural Guatemala, public health authorities would come through his village to give routine vaccinations. He remembers being physically held down for the shots, and that experience was so traumatic that to this day, he can't inject himself with a needle. He told me, "I'll cut something out of my skin with a knife, no problem. But a needle, a syringe, I panic." So that visit, we strategized. Could a trusted family member do it? What about an auto-injector so he didn't have to push in the syringe? What about something weekly instead of daily? In the end, we decided to give a weekly injectable medication with an auto-injector mechanism and a combination of newer oral meds. He met with other members of our healthcare team, the clinician, the dietitian, the social worker, who all helped to take care of him. Over time, he got to know us, and because the treatment plan made him feel in control, his walls came down. That built the foundation for a solid relationship, not just with me, but with our whole team, his medical home. He got to know me too. I would queue up pictures on my phone of my growing kids because he would always ask about them, and he would show me photos of his grandkids. The relationship like the one I built with Edgar and other patients are what made me fall in love with primary care. Those relationships are what sustain primary care doctors. On busy days is what gets us through. But our healthcare system prioritizes revenue over relationships. In the US, 35% of all medical visits are to primary care, but it only receives 5% of all healthcare spending. In practice, we feel that squeeze. We're asked to see more and more patients with less time, and it's burning us out. We're facing a growing national shortage of primary care doctors that's projected to triple by the year 2036. As primary care shrinks, care becomes more fractured, more expensive, and mistrust grows. Remember Anna? When she finally started her HIV medications, her health improved immediately. The investment that Dr. Mocktinger made in her paid off the moment she put her trust in him. It wasn't a prescription that brought her back from the brink of death. It was her relationship with him. And that's the diagnosis we're missing. We can all be part of the treatment. As individuals, we can have open and honest conversations about our relationship with healthcare, with our loved ones, and with our doctors. As doctors, we have to be open to those conversations and listen with empathy. Together, we can advocate for a healthcare system that values relationships. We can rebuild trust in medicine. It starts with a conversation. And hopefully, after today, it's a conversation you feel ready to have. Thank you.